Welcome to Salon Talks. I'm Mary Elizabeth Williams. Can social media save lives? A new Netflix series aims to find out. Dr. Lisa Sanders is a physician and educator at the Yale School of Medicine. You know her better, though, from her popular diagnosis column in the New York Times, which inspired the series House. She is also the author of Every Patient Tells a Story, Medical Mysteries and the Art of Diagnosis. And now her Times column has come to life with the documentary series Diagnosis. Hi, how are you this morning, Doctor?
I'm good. How are you?
I'm very well. So I want to talk about this fascinating, gripping, puzzling series. It's really something else. And it begins with you and your mysteries and your fascination with the way that we diagnose patients and your own transformation from someone who believed that a diagnosis was always a finite thing, that it was like solving a math problem, to it becoming a detective story. How did that evolve for you, and how have you now why do you now pursue this as something that's such an integral part of your career, your writing, and your teaching?
Well, when I came to medical school after a brief career in television. And during those, 10 years or so, I spent a lot of it covering medicine. And so that's why one of the reasons I decided to go to medical school. But really, during that time, I felt like I know medicine. I got this. And based on that kind of confidence, misplaced, I thought, I can do medical school. And I could do medical school. But when I got to the third year, which is when you actually get out of the classroom and go into the hospital and actually see how doctors work, I saw that what I thought of diagnosis was not completely wrong, but was wrong much of the time, or for the most exciting parts in any case. So I thought, and I think most people think, the diagnosis is like the multiplication tables. If you have this collection of symptoms, it's clearly this. 4 times 6 is always 24. And I realized that once I got to where doctors talked about these things, I realized that it was actually not the case. 4 times 6 could be 24, but it could also be something else. And you'd have to get more information to find out which it was. I found out that it was not the multiplication tables, but it was really Sherlock Holmes. I remember when I first made this discovery, it was in one of the education sessions that we have as medical students, and then as residents, and then as attendings. And it's called resident reports, or that's what it's called in my institution. And in this, everybody comes together, medical students, residents, established doctors, and hear a case presented the way it presents to a doctor, which is a patient comes in, you don't know this patient, you know what their history is, and they have a problem that they want to talk about. And so you slowly get the information about that, and then you get the exam, and then you think about what tests you want to order, and then you think about what could be going on. So it's this process of data collection. Sometimes there are red herrings, sometimes there are false leads, sometimes the key suspect is not obvious, not always in the room, so it had all these rhythms to it. I remember the case that I first heard. It was this young woman who had strangely swollen legs. And she turned out to have something called lupus nephritis. So it was an aspect of a disease called lupus, which it never was in house, that affected her kidneys. And so I remember thinking, oh my gosh, it's not the multiplication tables, it's Sherlock Holmes. This is a detective story. This is a mystery that has to be solved. And I was interested in it right from the start, in part because I realized if I didn't know that this is how diagnosis was, I figured that there were lots of people who didn't know. And I think that that's not an accident. I think doctors are pretty uncomfortable with the idea of patients knowing how much uncertainty there can be surrounding a diagnosis. And I think that they didn't like to talk about it. But I think that that's something that patients want to know. And I think that that's something that doctors should share. So I've been obsessed with this story ever since.
And as we know, and we continue to learn, the price of misdiagnosis can be so, so high and so fatal for so many patients. It is a big problem in our healthcare system. And at least having the transparency of saying we don't know is uncomfortable for doctors and for patients, but it certainly beats the alternative, which is treating,
Absolutely.
diagnosing, and treating.
And let me just say that there has never been a time in history or in medicine when you were more likely to get the right diagnosis than there is right now. I mean, I look at areas where people have gotten the wrong diagnosis previously. And to be honest, I did that because that was the way I could indicate to my readers that this was tough, that this was not easy. It also turns out to be true in the really tough cases that are not easy, that people often get the wrong diagnosis first. But diagnosis is a process. And as a process, it's been much more successful now than it ever has been in the past. We know more, we can test for more, we can think about more. That's a tremendous boon for patients. It's also makes things more difficult for doctors. There's a lot more to it. So, I mean, it's a great time. If you have to be sick and if you have to have something mysterious, this is probably the best time so far.
Well, I wanted to ask you about that because it is a great time. We are moving towards quote unquote personalized medicine. We have so many more options in terms of genetic testing and sequencing, and yet mysteries are still going to remain, and that can make it even more frustrating for patients who feel like we've exhausted so many more options than we may have a generation ago. And it also raises ethical questions in terms of how far are we going to go in the healthcare industry, because these kinds of tests and this kind of interrogation of symptoms does not come cheap. How do you feel about the ethical questions of that?
Well, I think the cheapest way to treat somebody is to get the diagnosis right. That's the least expensive way because you get the fewest number of tests and you can get right onto therapy. So you have the fewest tests, the fewest complications, and access to therapy that's going to be appropriate. So I think from an economics point of view, that getting the diagnosis right is the most important thing we can do. It's not easy. But let me just say, most of the time, most people get the right diagnosis very early on. I mean, most people have what most people have. I'm interested in the tough cases, the cases that people have gotten wrong in the past, because that way I can see human thought. That's what's interesting to me, is how people think through problems and how people deal with uncertainty. So that's why I focus on those. But let's be clear, most of the time, when most people go to the doctor, they get the right answer and they go on with their lives.
Yeah, even if it takes a couple of, even if it does take a little bit of referral and moving around a bit, most things are a little more straightforward for sure. But when you talk about the mind and the uncertainty aspect of it, that is a big element of what happens when you have a mystery, because then it becomes not just about the ailment itself and the symptoms itself, but the stress that goes along with it. And patients, as I think is very, very well documented in this series, then face questions of, is this all in your head? People tell me that this maybe is a psychiatric problem. And that is an element of this that then kind of goes hand in hand with the symptoms, because whether it's a psychiatric problem or not, the stress and the frustration and the ongoing pain of living with something that is not being treated adds another layer to the disease. Can you talk about what's unique about having a condition that is hard to diagnose from a psychological point of view?
Well, you must understand that I'm looking at a single person and looking at it from that person's perspective. That's how my column goes. That's how the show goes. But from a doctor's perspective, if I see 15 or 20 patients in a day, very few of them have something that's at all challenging to think of. They all have, if it's flu season and you have flu symptoms, there's a very, very good chance you have the flu. And most patients have that. Even when you have somebody who's complicated or has a new symptom, most of the time those symptoms go away when just on their own. And so a watchful waiting, here, let's take some ibuprofen, let's temporize, let's see if it goes away. Because in fact, most things do go away on their own. Either they're a virus and you get over it, or you pull something. I mean, it's usually something transient. And I know that it's very frustrating for patients to not have an answer. It's very frustrating, really, for doctors. And I think depression and anxiety and a lot of things that are absolutely everyday problems often manifest not as a psychiatric illness, not as a, oh my gosh, I feel so anxious and nervous, but oh my God, I have such a terrible headache. You know, the mind is part of the body, and when it's distressed, it expresses itself, and it can express itself in a lot of different ways. So when people hear doctors moving to see if it's a psychiatric illness, they shouldn't immediately think, oh, my doctor's dismissing me and just thinks I'm crazy. I mean, it's part of every differential. Now, let me just say, the doctors often, I suspect, and there's evidence to back me up, the doctors go to this a lot more readily for women than for men. It happened to me as a patient. And let me be honest, it's happened to me as a doctor. You know, we all have to gut check ourselves and go, really? Really? You're going to go there already? You know, so, I mean, it's a common problem just in thinking. We all are just compilations of assumptions and prejudice and bias and all that other stuff. We all, as human beings, have that. So, but it's still part of what a doctor must think about. Yeah. I know for a patient, it must be horrible and as a patient myself, it has been horrible to have people just dismiss my concerns as my doctor's favorite line is, oh, you're just old. Oh, I beg your pardon. I am not old. Speak for yourself, sir.
Yeah, that's not great bedside manner. And it does feel, I want to ask you about this because there is more movement now towards patients talking about their symptoms, talking to each other. And we are seeing more of a conversation about the way that patients are spoken to, about the way that they can be dismissed, especially women. Do you feel that the healthcare industry is taking notice of that? And is there more of an active movement on the side of healthcare and doctors to say, you know what, we really have to make sure that we are sensitive to this, and we are particularly sensitive to when women come in and say that they have pain or that they have mysterious symptoms, that we need to take that in the context of making sure that we assure the patients in a different way that maybe we would have even 10 years ago.
Well, of course, I think so. But I'm part of a teaching program that teaches people who want to be primary care doctors. So we are all about listening and eliciting the patient's story. You know, I mean, we have, courses in that. I mean, the residents are expected to master. We have them take cameras into the room with them so that they can record themselves with the patient. So, I mean, we care about that. And I think I believe ours is an extraordinary program, but I think it's also part of a growing concern in medicine that how a doctor hears a patient and a patient's story and how the doctor gives that diagnosis back is an important part of how medicine works, and one that hadn't been given enough attention previously. I think we're trying to address that. Our failures are ever so much easier to remember than our successes.
And it's really, as this series makes so beautifully clear and illustrates again and again and again with these different, very individual stories, is when you kind of move from the symptoms to the person. And once you see the person and you see his or her circumstances, his or her past, his or her experiences, you move much closer to getting a diagnosis. And it's not just about the symptoms, it's about the individual and everything that's gotten them to that place. And I think that the series makes that very, very clear. And that is definitely a lesson for patients in when they're talking about their symptoms. That's something I think we as patients really need to consider, that we don't just talk about our pain, we talk about our histories, but also that doctors are listening to that side of it as well. One thing that also this show does so well is it also puts patients in the context of their families. And it really makes clear the impact that an undiagnosed or undiagnosable condition has on parents in particular, but also on spouses, partners, children, and the impact that this has on the community. A patient is never alone. Why was it so important to add that element of the stories, to take these patients in context of their parents and their loved ones?
Well, of course, I mean, illness affects the patient, certainly, but it also affects everybody around the patient. And not to acknowledge that would be dumb. I mean, as a doctor, when we see the patient, we don't see their entire family or their husband or even their pets, their children, the rest of their family. We don't see them, but I think we all know that they're there in the room. That whatever we say about this patient or to this patient or figure out about this patient is going to have resonance with all those people. And I think that one of the things we teach residents is to ask them, to say empathetically and truthfully, it sounds like this symptom has really affected you. Can you tell me more about that? I mean, we encourage people our doctors, our residents, to investigate these aspects because, of course, people are not solitary creatures. We're very social creatures. And what happens to us happens to our entire family.
100%. And that's so huge. And it's so important that this is a very big element of this storytelling, that you put people in their context. And of course, I can't let you go without talking about the thing that is the driving element of this, which is the social media aspect of diagnosis, which is fascinating to watch and very really encouraging and makes you feel good about social media for a change. The way that people reach out and volunteer to help and volunteer their own experiences is a really beautiful thing. And crowdsourcing symptoms, it can be amazing. It's fantastic. And it feels like this is becoming more and more a part of the healthcare experience, whether or not you do it in the context of something like this, but as a patient yourself. You're going to start Googling around and seeing what other people have. The other side of that, though, of course, is, as we have ample evidence of the last couple of years, is that can also be a means of false information, misinformation. It can lead to health crises, as we have seen from the anti-vax movement. How do we temper this? How do we, as smart consumers and smart patients, weed through the vast amount of information and the vast number of people who are talking about their own symptoms and illnesses online in a way that is productive and useful and intelligent?
Well, social media is just an exaggeration of something that goes on all the time. I mean, well before there was Google, there was your mother, where you go, I have this pain, Mom. What do you think it is? We all do this. We talk to not just our mother and father, but, children, colleagues, friends. We vet our symptoms through our own networks. Google is just a much, much bigger version of that. But there's one important difference. We know that our crazy aunt has these nutty theories about this, that, or the other thing. And so when we ask their opinion, we know that it's possible that it will be different than other people's opinions. And maybe we know the context from which it's coming, and that gives us other ways to judge the information. On the internet, there's that old line, on the internet, nobody knows you're a dog. You don't know where the information is coming from. And I would say that bad information looks more and more like good information. And so just looking at the information itself does not tell you if this is reliable information or not reliable information. So I encourage my patients to use government resources. Maybe that sounds crazy, but really, if you go to anything NIH.gov or CDC.gov, you're going to get much better. You're going to get reliable information that you can trust and that you can use. It may not be complete, but it's going to be true and reliable and possibly something that will be useful. Because it all looks a lot alike out there. When you read a study, it's very hard if you don't know where it was published or who the authors are or what their reputation is. It's hard to judge.
Absolutely. Absolutely. Doctor, thank you so much again for being part of this conversation that all of us need to be having about healthcare, about the way that we look at disease, about the way that we approach it with that kind of openness and curiosity and transparency. The series is called Diagnosis. Doctor, thank you so much. I'm looking forward to seeing how the conversation evolves from here.
Me too. Thank you so much.